Welcome to SMA's Southern Medicine podcast. Practicing medicine in the southeastern United States presents unique challenges for healthcare professionals. The South's heavily rural population and limited resources require medical professionals to be more resourceful in their approach to providing quality care. SMA's Southern Medicine podcast addresses these issues by drawing on the experience of healthcare leaders who provide a multi-specialty, interdisciplinary team approach to medicine for the purpose of providing better care for the Southern patient population. Today, we are joined by Dr. Jason Wagner, a pulmonary and critical care physician practicing in the San Antonio area. He will be discussing the clinical features of critically ill patients with COVID-19, as well as reviewing various treatment approaches and touching on some of the challenges that the future holds. Thank you for being with us, Dr. Wagner.
Thank you for having me on. I appreciate the opportunity to talk about critical care as it pertains to COVID-19.
Did you ever think that your choice to go into pulmonary and critical care would provide you with an up-close and personal view of a virus like COVID-19?
That's a great question. First, I want to make sure that I pay tribute to all the frontline healthcare workers that have really stepped up to help care for others in our society. As you mentioned, I'm fortunate to reside in San Antonio, so I feel like in many ways we've been spared relative to other places in the country and the world. So for those of us in New York City, Detroit, New Orleans, and elsewhere where the prevalence is much higher, it gives me great hope to watch everyone demonstrate a high form of altruism. And I just wanted to make sure I touch on that before I get started. With regard to pandemics, I guess the short answer to your question is no. I went into med school in the early 2000s, right around the time that the first SARS coronavirus, burst onto the scene, if you will, mostly in Asia. And it really wasn't until I was a senior resident and chief resident for the H1N1 pandemic that I got an up close and personal look at a lethal contagious respiratory virus. Fast forward, if you will, close to 10 years or a little over 10 years, I don't think most of us in the United States practicing medicine have seen something like this before.
It has kind of taken the world, I think, just nobody has seen anything like this, like you said. Let's talk about the features of COVID-19. What are some of the distinguishing things that make it so unique and something so very different?
Well, I'll start by reminding everyone that I'm a pulmonary and critical care physician and not a virologist, but I've been trying to read as much as I can. I think first is that this virus is quite contagious, and during the viral replication phase, it seems like many individuals can not experience many symptoms. So whereas with influenza, when you start feeling ill, you wind up staying at home because you feel so badly, and in a way enforcing social distancing on yourself and thereby preventing the transmission to other people. It seems with coronavirus or COVID-19 that many people will have little to no symptoms at all, yet have the capability of transmitting the virus. And so from a public health standpoint, that is an enormous thing to challenge. From a clinical standpoint, I think we're still learning. What it looks like for the most part is that it's usually the onset of viral-like symptoms that include often, but not always, fever, cough, body aches, myalgias, and lassitude or weakness, with or without GI symptoms, which is reported to, somewhere around 15% of the time. And after about a week of those symptoms, or a week into symptoms, people can get really ill and land in the hospital with viral pneumonia. And we can talk more about that, whether or not it's the virus or the immune system's response to the virus. But in many ways, it looks indistinguishable to something called acute respiratory distress syndrome, or ARDS, along with some other features that somewhat are distinguishable.
Let's touch on what you just mentioned, virus versus immune system. Could you share a little bit more about that?
In my reading and from talking to others and trying to stay up to date on this, it seems that one of the most significant things that can happen to patients who have COVID-19 is well into their illness, after viral replication has been going on for quite some time, their immune system can have immunopathologic responses that are driven by cytokine release or cytokine release syndrome. And the immune system's response to the virus can have untoward consequences on the host or on the person themselves. And that can be directly toward the lungs, furthering lung damage, but it can also affect other organs in the body as well as patient circulation. And so most of the treatment modalities that many people are attempting, experimenting with, or trying to study are targeted for the most part either at viral replication or altering the adaptive immune response.
This is all very fascinating. And you just touched on treatment. So as we look to treatment, what challenges
Mhm.
exist when considering options for these critically ill patients who have been infected with COVID-19?
Okay. Well, I think that we should probably, when thinking about treatment, parse that apart a little bit and think about pharmacological treatments, other treatments that are medications under study, as well as sort of the treatment in general, if you will, toward patients that are critically ill on mechanical ventilation or at risk of devolving into respiratory failure that would require a mechanical ventilator. So I think first and foremost, we already know a good number of things about respiratory failure with prior literature that has sought to better understand acute respiratory syndrome. There's something called the Berlin definition of ARDS, which essentially is acute onset of bilateral infiltrates on a chest X-ray in a person who doesn't have clear evidence of heart failure, where the ratio of their blood gas oxygen level to how much oxygen they're being provided is 300 or less. And this syndrome has been studied for quite some time. I'm sure most clinicians are somewhat familiar with ARDS by now. There have been some seminal studies that have looked at the role of proper lung protective mechanical ventilation in ARDS. For example, figuring out a person's ideal body weight and then ensuring that the volumes delivered on a ventilator are targeted to minimize the amount of pressure or volume related trauma that the ventilator can cause with patients who are intubated, as well as positional changes that have been more rigorously studied within the last 10 years, specifically proning, which is putting a person on their stomach for the majority of the day while on ventilation to try and recruit more additional lung volume or surface area. So we already know that some of these things have evidence for ARDS. And for the most part, most healthcare providers are extrapolating the ARDS evidence or ARDS evidence to the treatment of COVID-19.
You have discussed challenges when considering treatment for these patients. Are there some aspects of this pandemic beyond the treatment that you have seen, experienced as a physician who is specializing in pulmonology and critical care?
That's a good question. So I think that the rapidity at which that coronavirus or COVID-19 emerged has really, to me, highlighted an interesting manifestation of clinical bias in some respects. We are in a data-free zone when it comes to considering alternative modalities of treatment for COVID-19. So when there is clinical equipoise, some providers will do less. They are the folks who want a rigorously high quality randomized clinical trial to validate efficacy for the things that they do on a daily basis. And most of us would agree that we feel more comfortable when we have randomized clinical trial data to as a basis for our decision making. With something like COVID-19, that's very challenging to do. Those things take time. Those things take coordinated resources, etc. So for some who will do less, others will do more. They recognize that there is an absence of high quality data, yet feel very compelled to do something. And when I look across the globe at how hard people are trying to do the right thing for patients, most folks tend to fall somewhere on that spectrum. Very few on either extreme, the majority somewhere in the middle. And so for much of what we're going to be talking about today, whether it be medications that are currently under study for COVID-19 or nuanced differences with regard to COVID physiology that may lend itself to things like awake proning, et cetera, there's a recognition there that that evidence is lacking, from speaking personally. And so when I see people using these various modalities, it's to me a good example of how people deal with clinical uncertainty. Some people do less, some people do more. And I think we're seeing that play out to some extent across the healthcare system.
Mentioned the clinical trials and treatments, and it is taking time, and so they're trying to fast track some of these drug therapies and get things to patients, and using drugs that are already in use, maybe not necessarily for COVID, obviously. Can you talk a little bit about the pharmacological therapies you mentioned,
Yes.
and
Yes.
share that with our listeners?
Sure. Yes. Let me just first say a little bit more about the physiology of COVID respiratory failure. I think it might lend some context. So one thing that many providers have noticed for a significant number of patients with COVID-19 is they have isolated hypoxemia. They have pulse oximetry readings that are very low, yet do not demonstrate ventilatory failure or hypercapnia or a massive increase in work of breathing. They look relatively well and have a very large oxygen requirement. And I think that's something that has struck many people as a unique feature for many who are suffering from COVID-19. Generally speaking, the role of management and respiratory failure I alluded to previously is proper ventilator management. In COVID-19, there is a movement by many to try to avoid intubation for as long as possible, using intubation as a last resort, if you will, and so we'll lower the threshold for an acceptable oxygen level on pulse oximetry and try things like high flow nasal cannula, where folks are accepting a lower oxygen saturation, utilizing awake proning, which I mentioned before is positioning someone on their stomach rather than in the supine position, with some data showing that you can improve your oxygen level fairly well utilizing this approach. What isn't well known is whether or not it ultimately alters the course for the need for things like mechanical ventilation or ECMO. So that's one thing that I think many people have recognized. And so with regard to, I just wanted to touch on that very quickly. With regard to,
important. Thank you for addressing that. Thank you.
Oh, my pleasure. So with regard to medication, the two medicines I noticed in the literature in general, more so than many others, the first is remdesivir, which is an antiviral medication that was studied with Ebola. And there were essentially two studies fairly recently. One, which was sponsored by the drug maker Gilead, published in the New England Journal. And I want to point out a couple important things about this study, because I found it a bit concerning at how rapidly it was taken up in terms of practice change, is that it was not a controlled trial. And so that, in my personal opinion, becomes less useful information. Essentially, this trial was a look at the compassionate use of remdesivir, where they gave it to some people who had COVID-19. Some were very sick, others not so much, and then some people got better. And so that really isn't useful, high-level evidence that are going to make a majority of people change their practice in a durable fashion. The follow-up study to that was done more recently in the Lancet, which was a better quality study, but still had some internal validity issues. And they looked at a wide number of clinical endpoints comparing remdesivir to those who didn't receive remdesivir. And for the most part, no matter which endpoint you looked at, except for time to clinical improvement, which is a little bit of an arbitrary outcome, the outcome metrics between remdesivir and the control arm were the same. And I think a concerning thing for me that it's hard to ignore, that one of the metrics that they looked at was viral replication. And this is a antiviral drug. And if we're going to be putting all of our eggs in the basket of an antiviral drug, I would like to see it affect viral loads, viral levels. And compared to placebo, it didn't. And I think there are a couple reasons why that could be the case. One is that it doesn't work. The other is that by the time folks are landing in the hospital with critical illness from COVID-19, it's not so much the viral replication that is the problem. That may have already been happening that week when they were at home before they didn't get admitted to the hospital. And for the majority of patients admitted to ICUs, it may be that adaptive immunopathologic response that people are trying to combat. So antiviral medication may just not be the right type of medication to be utilizing in an ICU setting. So I guess on that note, with hydroxychloroquine, which also has some in vitro antiviral data to support its potential use, there were two studies, one out of China with about 150 patients and another out of France. And there were essentially no concrete, meaningful outcomes with regard to survival or oxygenation in the French study. So there's not compelling data for either of these medications to support their widespread use outside of a clinical trial. And with hydroxychloroquine, there are some potential concerns about toxicity that people have mentioned, which include effects on the electrical system of the heart, QT prolongation, and cardiac arrhythmias. So in the absence of clear-cut data that suggests that these drugs are working, I think we need to govern our enthusiasm and exercise some caution when considering widespread use of these sorts of antiviral medications. So there's been some other medicines. Ivermectin, which is an antiparasitic medication, is also under study right now. And so I just think, unfortunately, we're not at a place right now where we can state with any sound degree of certainty that we have a medication against the virus is incredibly useful. So remdesivir to me is very similar to oseltamivir for influenza, which doesn't necessarily affect mortality, but may just decrease the duration of the illness, if anything. So hopefully that clears some things up.
Yes, touching on this as we're looking at what may and may not be effective. In your opinion, what are your early preliminary thoughts? Because, as you've said, there's not a lot of information out there regarding the antibody testing and the vaccines. We're seeing a lot here in Alabama, at least. Pharmacies are now offering the antibody testing, hoping that that might expedite a cure. And they're saying, oh, maybe we'll have a vaccine sooner rather than later. Do you have any thoughts on either of those?
Yeah, it's very hard to know where we are with that, in my opinion, because there are many different companies now devising their own antibody testing, and I'm not sure how well these tests have been studied and validated for widespread usage. We see reports out of China and Europe where small numbers of people who already had COVID-19 are contracting COVID-19 again. I'm not sure that is true. If so, how large of a problem that is. But for me, I think if I could ask for one thing, is that just the testing would be increased writ large across the country so that we could identify the people who had already been exposed. Wouldn't that be an anxiolytic for so many people? We could identify the people who've not been exposed, and obviously identify the people who are currently sick. And for the people who are already exposed and have antibodies against COVID-19, those people could then donate their plasma and help to better understand the role that convalescent plasma may have in the treatment of individuals who are currently infected. With regard to how long away are we to identifying a vaccine, I think the things that I think about there are, you can have a vaccine, but does it work? Is one thing that I think is going to take some time to figure out. And in my general understanding of, I mentioned this before, I'm not a virologist, but these things are pretty complicated. Coronavirus is an RNA virus. I wonder and have some concerns about how quickly we're going to have a vaccine that is working and useful and preventing, widespread reemergence of COVID-19 in the future. So I think that the other area to touch on with regard to treatment is several therapies that are currently being studied and in use to counter the immune response. So I mentioned before that many patients who are being admitted to the hospital, particularly into the ICUs, are exhibit many features of cytokine release syndrome. And so, for example, a lot of patients who are coming in have incredibly high levels of ferritin, of D-dimers, often well over 1,000, 2,000, CRP levels well into the hundreds, elevated LDH, interleukin-6, if you can send that test. And they also have commonly, but not always, normal white blood cell count. But if you look at the differential, they have very low lymphocytes. And so these folks are coming in, and there's a concern that the immune response is at this point doing more damage than viral replication is. And so many treatments that folks are hearing about or reading about are in play in many ways to alter or adapt this immune response. So one very common medication that is in use in many places are corticosteroids. And the dose that you'll see is somewhere solumedrol in the range of 40 milligrams to 60 milligrams. And this isn't for use in early COVID-19 infection. People shouldn't be being prescribed steroids at home with COVID-19. We're talking about folks with bilateral pneumonia, ARDS physiology. In those patients, many people are using salumedrol or dexamethasone or prednisone. The thought there is that you're trying to quell the immune response that may be driving further lung injury, as well as hemodynamic instability and other end organ damage. Building on that concept of cytokine release syndrome, another medicine that is under study is a medicine called tocilizumab, which is a monoclonal antibody to interleukin-6. And this medicine was used as an antidote therapy, if you will, to CAR T therapy, which are re-engineered T cells to combat malignancy. And those re-engineered T cells would often lead to a massive cytokine release, and interleukin-6 monoclonal antibody was sufficient to nip that in the bud, if you will. I think it's an oversimplification to assume that the cytokine release of CAR T therapy is exactly the same as COVID-19, but it may or may not work. I think at this point we just don't know, and that's why it's under study. But I will say that this medication may have some risks associated with it, and the risks that most people are concerned about is long-term downstream immunosuppression. So the jury's out on that one. The other thing that you'll see in use is convalescent plasma, which is plasma derived from individuals who have already contracted and gotten over coronavirus or COVID-19. And this may work against both viral replication as well as helping to adapt the immune response in a targeted fashion. The FDA has approved plasmapheresis for the treatment of COVID-19, which is essentially putting a catheter in a patient and pulling off many different cytokines and proteins and potentially viral particles and virions to drive down the inflammatory response, which I think is a very promising concept, because with a syndrome, I often worry about targeted therapies that go after one cytokine. Plasmapheresis would just deal with all of them. Now, whether or not there's untoward consequences with regard to subsequent infection, I think is too soon to say, but you may see things coming out in the literature looking at plasmapheresis for cytokine release syndrome associated with COVID-19. The other thing that I just want to make sure we touch on, which has been in press definitely for the last couple of weeks, is this concept that for many patients who get COVID-19, they're having blood clotting issues. You're hearing from providers that the dialysis circuit or the central lines are clotting all the time. There are patients getting deep venous thromboses and pulmonary emboli who are on prophylactic anticoagulation. There are autopsy results that are demonstrating that the lungs of some patients with COVID-19 have microthrombi. And there's some evidence also that larger vessels are also at risk with strokes and cardiac arrest. So there's some data out of China that looked at the association between D-dimer level and clot. And many folks have decided to therapeutically anticoagulate patients with COVID-19, unless obviously there is an absolute contraindication, once a D-dimer level crosses a certain threshold, for example, 1500. The one thing we haven't touched on is the resource strain that a contagious virus puts on the healthcare system, and doing things like serial Doppler ultrasonography on many patients with COVID-19 has resource implications. So many people have adopted for therapeutically anticoagulating unless there's a obvious reason or risk not to, and then maintaining that anticoagulation throughout the remainder of the hospitalization with then short-term out-of-hospital follow-up. So there's the antiviral arm, there's the cytokine release arm, and I think you're seeing a lot of work in both of those domains, trying to better understand how best to combat this disease.
What challenges do survivors of COVID-19 face? You've mentioned as they are recovering or in treatment that clotting and VTEs can be an issue, but what do you think some of the other challenges may be on the horizon for these patients?
I am so glad you asked that question. So let me back up first just a bit, and then provide some context and then delve into why that's maybe even more significant for COVID-19. Over the last 10 to 15 years or so, the critical care community has developed a much better understanding at what surviving critical illness looks like. Fortunately, we've made advances in critical care where our mortality rates have gone down, namely for acute respiratory distress syndrome and for things like septic shock. And for many of the patients that survive ARDS, septic shock, they struggle with certain things like neuromuscular weakness, cognitive impairment, post-traumatic stress disorder, anxiety, and depression. The majority of patients with ARDS have normal lung function 6 to 12 months later, even though the primary reason for their ICU admission was a lung problem. So this entity that I'm talking about, or the syndrome, if you will, of some combination of neuromuscular weakness, PTSD, anxiety, depression, and cognitive impairment, has been coined post-intensive care syndrome. And if you survey many individuals who have survived critical illness, they'll have one or more of these features. Now, some lucky folks won't have any, but it's a real problem. And I think in many ways, pulmonary critical care doctors have been working hard to increase public awareness about PICS, or post-intensive care syndrome. Interestingly or concerningly, there's also something that's being studied called PICS family, which are what are the implications for surrogates and loved ones and family members for people who are admitted to intensive care units and put on ventilators and are at high risk of mortality. And it turns out for many family members or caregivers or surrogates of patients admitted to the ICU, they also struggle with PTSD, anxiety, depression. And so COVID-19 has all of those risks. It causes respiratory failure. Put on top of that, it seems like people are very procoagulant and may have more lung issues subsequent to that, unlike normal, if you will, ARDS. But they're at risk for all of those things. So the cause of the neuromuscular weakness and the cognitive impairment and anxiety and depression and whatnot is actively under study. Is it the amount of sedatives that are used in the ICU? Is it the critical illness itself? These are all things that are trying to be sorted out. But what I worry about, and what's been very hard, I think, for that every healthcare provider would relate to, is one thing that I pride myself on as a physician is sitting and talking with patients if they have the ability to communicate, but definitely getting to know, helping families get through periods of critical illness, family meetings, helping to better understand a person's values and preferences so that I can be confident that I'm making the best decisions for that person. And part of the response to managing this pandemic has been social distancing, which I agree with. And what that means on a hospital level for the most part is no visitors. And so we have people that are critically ill with COVID or without COVID. So if you get a heart attack or a COPD exacerbation or new renal failure, you don't have your loved ones next to you like you used to just a couple months ago. And I think that definitely increases the anxiety and the stress of the experience for the patients and for their loved ones who aren't there to be there for them. But it also makes our jobs more challenging. So, I mean, our nurses are incredible. Our respiratory therapists are incredible in many ways of filling in for the inability to have families visit. So post-intensive care syndrome, COVID-19, for better or for worse, I think is going to help bring more social awareness about. These folks are going to have some issues with regard to rehabilitation, and they need dedicated pulmonologists. And we're thinking actively about post-hospital discharge clinics for COVID patients so that we can be sure that they get the care that they need, whether that be physical therapy, whether that be an antidepressant, whether that be further management of their lung disease.
What other treatment modalities are available for those who are experiencing respiratory issues, respiratory failure?
Yeah, I'd love to take that on as well. So one thing that some centers are doing, if they have the capability and the bandwidth to do so, is something called extracorporeal membrane oxygenation, or ECMO. And that is essentially using a machine and a filter and a pump to bypass the lungs and remove carbon dioxide, add oxygen in, and then put that blood back into the person's body, essentially acting like the lungs. The one thing that ECMO can lend itself to, in addition to adequate oxygenation and carbon dioxide removal, is minimizing any lung damage that is associated with mechanical ventilation. There are a lot of data out there that show that if folks have too high volumes or too dramatic of a swing in pressure on mechanical ventilation, it can drive lung injury. And for COVID-19, which is contagious and staff is spread thin and maybe respiratory therapy isn't in the room as much, et cetera, there's concern that the ventilator management for COVID-19 patients may face additional challenges that others don't. And so there's some data. There's one study from 2018 that looked at, for patients who had severe ARDS, proning or positional changes versus early ECMO. And that study's results, unfortunately, were somewhat inconclusive. Their primary outcome was mortality, but it was powered, I believe, to detect up to a 20% difference in mortality. So it wasn't statistically significant. But what was also found in that trial is many patients who were randomized into the control group wound up crossing over into the ECMO group. And many people feel that that diluted the effect of ECMO. So it's very possible that early ECMO in patients who have severe acute respiratory failure can result in improved outcomes in select patients. Patients who can withstand receiving ECMO, who have single organ dysfunction, namely lung disease. I think it's quite possible that that could be superior in many instances to conventional modes of mechanical ventilation that often require high amounts of sedation, as well as those positional changes. One thing of note with ECMO is that you can be on ECMO and be somewhat awake. And so depending on the outcome you select to study, can often drive the results of the study. So I think we should have additional trials looking at early ECMO compared to early proning with some folks who have acute respiratory distress syndrome.
This has been an absolutely wonderful conversation, Dr. Wagner, and we appreciate your time today. Before we end for the afternoon. Do you have a pearl of wisdom or a piece of advice that you would like to share with our listeners today?
Well, I appreciate that, and it's been a pleasure as well for me. I'm not sure I would define this as a pearl of wisdom, but I do think that we need to really take care of each other, and that includes the folks that have survived critical illness from COVID-19, as well as their families. I do think that the struggles of survivorship with regard to critical illness are below the radar in many respects, and these folks are going to need some understanding and some support from both the healthcare system and their communities. And one thing I worry about is once a COVID positive, always a COVID positive. And I worry that folks are going to be treated like they're different because they got COVID-19. And I don't think we do that when people get through other acute infections. So I think we need to lean on science and rely on science and be there for each other.
Thank you again for your time today. And also, thank you for what you are doing and for being on the front lines of this and for taking care of us and all of those patients with COVID-19. We truly appreciate the sacrifices you're making during this time as well.
Thank you very much. I really appreciate that. And thanks to everyone else out there trying to do the right thing.
Thank you again for joining us. To subscribe to additional SMA podcasts, please visit sma.org/podcasts.